Everyone. Thank you for joining us for our webinar on workplace interventions to tackle flu season during the COVID-19 pandemic. This is Karen O'Hara, your moderator. I'm the Director of Marketing and Communications with WorkCare. Thanks so much for joining us. Be willing to bet many of you join us for our weekly COVID-19 webinar, and this is a special event we're just going to be doing once. You'll be able to find a copy of the recording on our YouTube channel within about 24 hours. For the duration of the session, you'll be on mute. We will be accepting questions throughout the session using the Q&A function in Zoom. If you use the Q&A instead of the chat, it's a little easier to make sure we answer all your questions. You can use either function, but I recommend the Q&A. The session will last for no more than 1 hour. Our speaker has allowed plenty of time to take all your questions in that hour allotted. So I'm really happy to introduce you to our speaker today. Many of you haven't had an opportunity to meet him yet. Christopher Jankowski, MD, MPH, is our Senior Vice President for Operations. He just joined us over the summer, and we're really thrilled to have him on our team. Dr. Jankowski is board certified in occupational medicine and neurology. He has expertise in infection control and prevention, which is particularly well suited for this topic. And experience includes a leadership position at the Food and Drug Administration, which has been in the news a lot lately. And he is a retired U.S. Navy captain. And maybe if we encourage him, he'll tell us a little bit more about his background. So I'm going to turn it over to him. Dr. Jankowski, welcome.
Hey, good morning, everyone, or good afternoon for those in different time zones. Really excited to be sharing this information with you today. So I think I only have a dozen slides, so there should be lots of opportunity for questions. Just if someone on the line can tell me they can hear me okay, just so before I continue, is sound coming across okay?
I can hear you fine.
Perfect. And everyone can see my screen?
Yes.
All right. So again, I'm going to get started, and we'll talk about numerous things as we go. Please write down questions that you have as we move forward. I'm trying to advance my slides here. These are today's topics. I think this is what was sent to you in the email, these 4 topics. I added a 5th, which is talk a little bit about the new COVID vaccine that may be coming out in the months ahead. So first off, we're going to talk about how this flu season preparedness differs from prior years as you're planning on how to administer the flu vaccine. We're going to secondly talk about the Southern Hemisphere. Keep in mind that the flu season happens during the winter months. During our summer is the Southern Hemisphere's winter. So they've already been through the flu season. Thirdly, we're going to talk about campaign strategies. Consistently questions that come up from a lot of my clients is, what are we going to do with all these remote workers? It used to be relatively easy whenever work site. Now that everyone's remote, it becomes a little more complicated. And fourthly, we're going to talk about what's the effect going to be on your workplace when COVID-19 and the flu are going to occur at the same time, potentially. We'll see how, we'll talk about that as we move forward. Slide number 3. Most of you already know this. Anyone who's lived a full life has had flu vaccines, and you understand the basics, but I just mentioned here that we try to get all of the flu vaccines administered by the end of October. But realistically, we continue to give flu vaccines to those who have not been able to get it through December, January, February. You know, as long as there's still influenza virus circulating, and as long as the vaccine is not expired for that season, we'll continue to give it. There's really very few contraindications. I mean, if you have a few thousand workers on your work site, almost everyone can get the flu vaccine. At the FDA headquarters, when I worked there, it was a headquarters in Silver Spring, Maryland. I think we had 8,000 people on campus. And I think the people who had contraindications could probably be on a single hand. Maybe, you know, very few people is it contraindicated, but the standard contraindication is listed here that I put from the CDC website. If there's a history of a severe allergic reaction to the vaccine or its components, and the different vaccine components are on the package insert. Or secondly, the egg allergy. But if you look at the CDC website, most people with an egg allergy, it is still recommended that they get the influenza vaccine, except if they've had a previous severe allergic reaction to the influenza vaccine, and then that is a contraindication for future receipt. I've worked a lot with different immunologists and infectious disease and rheumatologists when we have somebody who may have had an unusual reaction to the influenza vaccine. And it's something which is, it's pretty complex. If somebody says they have a severe egg allergy and they don't want to get the flu vaccine, that's realistic. I would not push it on them. But for many others, they can talk to their doctor and probably still get a flu vaccine. There are 2 precautions listed on the CDC website. One is if you have an illness at the time you come in to get it, then you should wait until that illness goes away. And then you can give the flu shot after that illness is over. And the second one is if you've had Guillain-Barré syndrome in the past, which potentially could have been triggered by an influenza vaccine, which means it occurred within 6 weeks, then oftentimes for those people, we recommend they don't get future flu vaccines, just so that they don't have another potentially immunologic reaction and get another episode of Guillain-Barré. Super rare. There aren't that many people out there. And even if they are out there, it's super rare they're going to have a second one, but would rather be cautious. So that's really it. Now, if these are for inactivated vaccines, if it's a live vaccine like the flu mist, there are a couple other contraindications, but I won't go into that. I just want to emphasize that most people should be able to get a flu vaccine. All right. Symptoms. All of you remember previous flu seasons, and you remember having these symptoms yourself, or coworkers having these symptoms, or your children having these symptoms. So I don't need to go over all of these. I'll just mention that you guys are aware of these flu-like symptoms. And then I want you to ask yourself a couple questions, and I have these listed here just of your own previous experiences. The first question is, what are your own memories? And I'm going to share a couple of mine. I spent a number of years in Pearl Harbor, Hawaii. I was the fleet surgeon for the submarine force there for a few years, and everyone was young. I mean, the average age on these submarines is like age 24. They were all vaccinated. It was required. The military, everybody got the vaccine. And we were living in Hawaii. And frankly, I don't really remember this ever really being a problem. The flu season came to Hawaii, came to the submarine force. It didn't really impact our mission. So that's one memory. The second memory is being in Washington, D.C. At the FDA, where I had a few dozen people working for me, and they were all MDs or PhDs, and their average age was probably 40s, 50s, 60s. And every season, half of these guys during the season, half of these men or women would email me and say, I'm not feeling that good today. I'm gonna take some sick days, or I'm gonna just work from home. And it really did impact us during the wintertime. So around the holiday period, December and January and February, it was very common for me to get at least one email a week from an employee asking me to take some time off. So, it really depends on where you are on the individual impact of your business and your company. So think about that and what you've had in previous years, and you'll sort of have an idea of what may be coming this coming year. And then the second thing to think about is, have you seen employees with the flu coming into the workplace? And again, I'll share 2 brief stories. Is one story, I remember it was the middle of January, we had an important meeting at the FDA with one of the companies that was submitting for a flu vaccine, and I'm sorry, for some vaccine. I don't remember if it was flu or some other vaccine. And we had about 15 people who were supposed to be at the meeting, and probably only 10 showed up. And for whatever reason, it was a bad week for the flu. And of those 10 who showed up, looking around the conference table, like at least half of these people looked sick. I mean, they had sort of like a red nose, bloodshot eyes. They looked really fatigued. A handful of them said, I just came in for this meeting, then I'm going home. And I remember looking around the meeting and saying, this is sort of ridiculous. Like, most of these people are physicians. They know they shouldn't be coming in sick, but they are anyways. But in the big scheme of things, people are still going to the gym and being infected, and people are still have children that are being infected in school. So I guess nobody really got super upset. And in a way, it was sort of a test of strength that they actually drove themselves in when they weren't feeling well to come to work. Those days may be over, at least for the next couple of years during COVID, where people who were sick with the flu symptoms should probably not be coming into the workplace. The second brief story is I worked for the National Science Foundation on the side, helping them out with Antarctica, and I actually helped them write up their policies on their medical panel. And then they asked me to go down to Antarctica and to fly down to Christchurch, New Zealand, and then get on a C-17 to go down to McMurdo Station. And we showed up at Christchurch, New Zealand. We do the airport. A special airport. They give us all this gear to wear. They ask all of our measurements ahead of time, and they give us a parka and thermal underwear and boots and then while we're getting dressed, about to get on board the C-17, a nurse would go around and say, "Yeah, are you sick today? Do you have any infectious disease you're going to spread in Antarctica? Or do you have the flu? Or do you have a fever?" And they would take our temperature. And I looked around and I thought to myself, none of these 50 people getting ready to get on the C-17 is going to admit, you're not going to admit not feeling well when you're about to have a lifetime experience. And I think that type of a feeling like, well, I'm sort of a little sick, but I don't want to admit it. I need the job. I need the paycheck. I see that with some of my companies, that there's concerns that people may continue to come to the workplace during the flu season and during COVID season. And that's something which hopefully you're going to have an organizational climate which is going to be respectful of these nuances. So just keep that in mind. Some places may have a lot of people coming in with flu-like symptoms, and you may not be able to differentiate them from COVID. And there's still this requirement to keep a safe environment for all of your employees and to have COVID patients not come to the workplace. In addition to flu, but again, there's much more anxiety about the severity of COVID. All right, next slide. Why is the season? As I just mentioned, the CDC thinks it's likely that both flu and COVID will be spreading at the same time. So it's even more important you get the flu shot. We don't want this confusion of a sick worker coming in. So the less sick people come in, the better. I think last year's flu vaccine was about 40% effective. And even those who got the flu, it was often of lesser severity. So it's really important to get the flu shot. It's going to make your lives easier for all of your companies if you have less sick people, and you're not going to have to figure out whether this is COVID or whether this is influenza A or B. I personally had a patient who I called last week, or who called me last week, who said that his girlfriend was really sick, and she went to see the emergency room, and she had a negative COVID test and a positive influenza test. And he asked me if he needed to be quarantined, and I said, no, I think you're probably okay. But that was the first that I've heard that someone actually that was tested for the flu and has a positive flu. Earlier this week, a colleague of mine also said they had a similar situation where someone tested positive for the flu. So we are actually in the flu season now. It's only 2 cases, but that's 2 cases of positive influenza tests. So we're going to see more of this. And again, the CDC recommendation is, and the second bullet point, all people over 6 months are going to get the annual flu vaccine. It's recommended.
Dr. Jankowski, it's Karen.
Yes.
I'm just interrupting for a second. One person just commented that they've had cancer twice in their life without going into any details. But it makes me think about how people with immune-compromised systems or who are treating cancer but still working and getting exposed have higher risk. And I thought of 2 scenarios in my background about the flu, and one is getting sick while traveling and then having to get home, and there's like no choice. You have to go home and get on a plane or some other public transport, not feeling well, knowing you're not feeling well. It's kind of like the inverse of the Antarctica scenario. And then another scenario that comes to mind is people who say, oh, I had the flu shot last year, but I got sick anyway. It's not effective, so why even do it? Or there was another strain that turned out to be more virulent, and it wasn't even in the vaccine, or it wasn't as effective, so they're more skeptical about the effectiveness of getting vaccinated, and that makes a difference.
Yes, those are great points. I will reiterate that, or I'll mention the more that those who are listening to this webinar, if they speak with other people in their organization, with human resources, legal, other building managers, and they talk about some of these issues ahead of time, it's better than having a knee-jerk reaction where on Friday night you get a phone call again about somebody who's stranded at another airport and thinks they might have the flu and can they get on a plane. So again, these are great things to bring up, and hopefully internally you guys can discuss all these things. And the flu vaccine is not 100%. It's not perfect. Every year, scientists around the globe try to figure out what they're going to put in the Southern Hemisphere flu vaccine and what they're going to put in the Northern Hemisphere flu vaccine. And they have to decide months ahead of time because they have to make hundreds of millions of doses. And so sometimes they're spot on and they have really good effectiveness, and other times, the vaccines shift during the months where they have made the different strains. There's usually 4 strains in each flu vaccine. It's a quadrivalent normally, sometimes trivalent. And so we don't always get it right. Last year, I believe the effectiveness was about 40%. So 40% isn't bad. And again, even if you got the flu and you had the vaccine and you think it doesn't work, you probably still had lesser symptoms than you would have otherwise. So personally, if you talk to more than 90% of physicians, we all believe in the flu shot. And I think it really does work, but there's a lot of chatter on social media and other things that there are some people who really don't believe in the flu shot. And I can't do anything about that except, my opinion is the flu shot's an important thing to get. All right, you want me to go ahead and go to the next slide, or any other comments or questions?
No, go ahead. Thank you.
Super. Yeah, feel free to interrupt. I sort of, it's nice to have to make sure people are listening and I'm not just here by myself. I'd rather have a live audience. It's always weird to be these webinars. So, all right, so I'm gonna go on to slide 6. This is the flu symptoms are on the left side, the COVID-19 on the right side. And these are both directly from the CDC. And really, they're almost exactly the same. The only difference is that on the right-hand side for COVID-19 is about halfway down, it says new loss of taste or smell. And I'll tell you, this is real. There are people in the past who told me they had a stuffy nose from the flu, but and because their nose was so stuffed up, they couldn't smell as well. But this is not just the stuffy nose. This is actually from the COVID-19 virus. Likes to get up into the nose, and it affects the supporting cells of the olfactory neurons. And because those supporting cells are affected, this is at least what the science thus far has shown, is that the olfactory nerves are not working properly and you lose your sense of smell and things don't taste as well. And over time, that will return as you get over the virus. Most people, their sense of smell will come back. But I'm seeing this from a lot of people that I'm talking to. I frequently call people who are employees who have a positive COVID test. They're just employees getting routine screening. They don't have any symptoms. They think that they're fine. I call them up and they say, oh, I'm doing fine. I just came back. One young lady said, I just came back from like a 3-hour workout. I'm feeling really good. My nose has felt a little weird recently, but I feel great. And a few of my friends have COVID, but I didn't think I would ever get it. And I say, well, tell me more about your nose. And she's like, oh, I don't know. It's nothing. And I said, well, do you have a sense of smell? Sometimes it'll affect your sense of smell. She's like, no, I don't know. And I said, well, do you have any like coffee in your house, any coffee grounds? And that might give you an indication. And she says, well, hold on for a minute. And then there was this pause for about 30 seconds or a minute. And then I hear this very mild sort of weeping. And then she was very sad. She'd been very upbeat before. And she says, I can't smell the coffee at all. Like there's absolutely no smell of coffee. And so it seems like that's sort of the most emotional instance that I had talking to someone on the phone with a positive COVID test. But it's pretty common when I talk to people that they, even though they think they have no symptoms, they do have a loss of smell. But by and large, you're going to get these other symptoms that look just like the flu. And I had a guy who I called who said he was sick the previous week after going hunting. He went to his doctor like 5 days later on a Thursday and told the doctor he had all these things. And the doctor said, oh, it's probably just a cold. Here's some antibiotics. And you're getting a COVID test at work the next day. So on Friday, and then on Friday, he got the COVID test. And of course, it came back positive for COVID. And so, you know, a seasoned physician is going to have a hard time figuring out which one you're in. There's more scientific study publications coming out where maybe at some point a really good clinician will say, I'm 80% positive you have COVID, or I'm 80% positive you just have the flu. But there's so much overlap, except for the sense of the loss or smell is pretty specific, it seems, for COVID-19. But you're not going to have physicians who are really going to feel confident, you know, greater than 90% that it's one or the other. So just keep that in mind as you're working with your employees. You're gonna have this issue, and we'll talk about that a little bit later when we talk about testing. All right, the next slide. I just have 2 slides here on the Southern Hemisphere. It's a little bit repetitive. Just bear with me. I just want to reinforce that the Southern Hemisphere, things seem to be going pretty good. This first slide, this bullet point, the World Health Organization sort of points out that you know, be a little cautious with the Southern Hemisphere data. It may not be the same in the Northern Hemisphere with Europe and the United States, but what we've seen so far is that, you know, different countries have different health-seeking behaviors. They have different routines. They have different testing priorities and capacities. Second bullet, very similar. These different countries have different, you know, hygiene and physical distancing measures. Some countries, they're really, really good about wearing a mask. Other ones, not so much. So we may not be the same in the Northern Hemisphere as the Southern Hemisphere, but this is still good data to be thinking about. And then the third bullet on this first slide is that globally, the influenza activity has been reported at lower levels. That's pretty good. That's a nice sign. Hopefully we'll have the same. Despite continued or even increased testing for influenza in some countries in the Southern Hemisphere, very few influenza detections were reported. So really good news there. The next slide, I'm just going to continue on. In the temperate zones of the Southern Hemisphere, influenza activity has remained record low compared to previous seasons. In Oceania, influenza-like illnesses and other influenza indicators remain below normal levels. Influenza testing in Australia and New Zealand has been maintained or even increased, and yet they found very few influenza viruses. Keep in mind, both Australia and New Zealand have been pretty good as far as their mask and their social distancing, so it's not a surprise, but it's good. Hopefully in the US, we will see similar things for our Northern Hemisphere flu season. South Africa, no influenza viruses were detected in the influenza-like illnesses or pneumonia samples from sentinel sites, but they did see the respiratory syncytial virus and the SARS-CoV-2. World Health Organization is referring to the actual virus, which is SARS-CoV-2. That's the same as COVID-19 infection or illness. Were detected among pneumonia samples. So that there were some COVID-19 reported in South Africa, but it was lesser. And in South America, there were a few influenza B virus detections reported in Argentina, and severe acute respiratory infection cases continued to decrease in Chile and return to below the epidemic threshold, which was sort of in alignment with the decrease in COVID-19 detections. So far, Southern Hemisphere hopefully has been a less intensive flu experience, and hopefully that'll come to the Northern Hemisphere as well. So those are those 2 slides. Flu vaccine campaign strategies. The difference really between this year and previous years is you should postpone this for people who have suspected or confirmed COVID-19, regardless of whether they have symptoms. So in past years, if somebody had symptoms of an infectious illness, you would not give them a flu vaccine. This year, even if they don't have any symptoms, if they have had a positive COVID test within the previous 10 days, assuming they're asymptomatic, at the end of 10 days, they finish their isolation. But for those people who've had a positive COVID test, you're going to have to wait until they've met the criteria to discontinue isolation. And then you would give them the vaccine. So that's one difference, is that asymptomatic people with COVID-19, you're postponing their vaccination. Second difference is the providers of these immunizations have to adhere to all the rules we've been doing for COVID, right? Physical distancing, mask, respiratory hand hygiene, decontaminate the surfaces. So a lot of this is going to take extra time. I was a university surgeon at Uniformed Services University back when I was residency director there. And one of my few jobs there was to make sure that we had a one-day flu vaccine event where all 500 medical students would be vaccinated in the same morning. So we just set up these tables. These are all young medical students. We just line them up, and first we'd have the first year students, the second year students, and we just sort of knock out almost all these students in a single morning. And it was super fast, super efficient. You had a few people doing this, everything's recorded, and you're done. Nowadays, it's going to be more complicated. You have to line people up 6 feet apart. The whole thing is when you're providing immunizations in your companies on site, it's going to take a little more time and be a little more expensive, I suppose, to do that. So just sort of keep that in mind. It's not as easy as in past years because we're still within the COVID epidemic. All right, so those are two main differences. And then on this slide, I just threw in, hopefully you guys already have strategies in place. You've already had your campaign going. Upper left, on-site vaccination. Oftentimes you do a little health fair or a specific day, and there's a little table set up somewhere, and you just get a lot of people done on single days. And then throughout the season, they can go to your health clinic office and talk to the nurse and get a flu shot then for the stragglers throughout the season. So that's the traditional on-site. On the upper right-hand side is the off-site. A lot of guys are going to this. They have thousands of workers who are now working from home. They don't want them in the office, And so these workers, they've set up arrangements with local pharmacies, CVS, Walgreens, whatever. And they try to make it convenient. They don't want their workers leaving at, 10 in the morning to get a flu vaccine at the CVS. And then there's a line of 30 people. And it takes 2 hours to get a flu vaccine at the local CVS. So they're trying to make arrangements with local pharmacies or local primary care providers to get their flu vaccines in a timely manner. Again, you'd like to get them all by the end of October. So it's a little extra effort if you can't do them on site. Bottom left, this is actually from the CDC website that just has a little thing about drive-through services at fixed sites, curbside clinics, mobile outreach units, home visits. These are all things which the CDC recommends as alternatives. And then bottom right corner, I threw incentives in there. I'm not sure exactly, what this means. I just know that you need to talk probably to your legal department. If you're a healthcare facility, you can require it. Okay. It's if you want to work here as a nurse or a physician, you need to have a flu shot. Otherwise, it's a risk to our patients. And even then, there are, at any major medical university, there are some nurses or healthcare providers who don't want to get a flu shot. And so there's usually some type of an out for those people. I've also done some work for the National Vaccine Injury Compensation Program. And I occasionally get cases where there's a nurse at a hospital and she doesn't want to get her flu shot. And she finds a note from her chiropractor and says, I don't want to get a flu shot. And she ends up getting it anyways against her will. And then there's disasters happen, then she's oh, I got it. And now I feel achy and now I have tingling and I have all these issues. And then she files a workers' comp claim and she files a lawsuit against the government through the Vaccine Injury Compensation Program. And it just goes on for years, and it's so much pain and suffering for this whole situation. So if someone really strongly feels like they don't want to get a flu shot, I personally don't recommend pushing that one person beyond their comfort level. That's just my own personal recommendation. And most people you can't enforce legally to have all of your employees get a flu shot. And then you're left with, incentives. Sometimes people have health incentives, hey, if you go to the gym, you get a certain amount of points in our program, or, if you have a certain amount of steps, or if you join a weight loss challenge and you sign up for it, even if you don't lose any weight, you get some points for there. And maybe if you get a flu shot, we'll give you some points to there. If you get enough points, then we'll give you a gym bag with our company logo on it. So, there are probably ways to incentivize your workforce. But again, talk to your team and see if there's some way you can somehow incentivize people to get the flu shot. All right, so that's all for that slide. What if you have COVID and flu cases simultaneously? Well, we might. That's certainly something which can happen. And because they're so similar, it's going to be hard to tell the difference. Diagnostic testing, that's the third bullet on here. I don't have any magic for you today. We can have another webinar later to talk about this. There are certainly a lot of COVID tests out there. You're already aware of that. And there are certainly flu tests that different emergency rooms and doctors' offices are going to have to do a quick, rapid flu test. There are companies that are putting together now, very hurriedly putting these together with a sense of urgency where you can test for flu and COVID at the same time. These are sort of yet to hit the market, but you will probably have salesmen calling you up, offering you certain types of tests. And again, I'm not going to go into the details of that, but that would sort of be the ideal thing where you can test for both at the same time. All right, so briefly, I was sort of asked to talk about the COVID-19 vaccine. So keep in mind, I spent 5 years at the FDA once I retired from the military, and I was a branch chief with 12 physicians working for me, doing almost all vaccine adverse event reporting and approvals of the new vaccines. And then I became the division director for about 30 some people, where I had like every vaccine in the country, all the surveillance we were doing nationally on every vaccine. And then I became, at the office level, the head of the associate director for policy, for medical policy. So I have a lot of experience. I've sat in a ton of meetings for vaccine approvals. So I have a lot of knowledge on this, but a lot of it is proprietary or whatever, and I don't really want to get into the details. But I just want to point out that, as you know, there are hundreds of vaccines around the world being developed. The Chinese and the Russians have already, started giving them to their populations. I think particularly the military, I think the Chinese military was going to immunize they were going to immunize the entire Chinese military. We don't have a lot of data on the Russian and Chinese vaccines right now, but they are out there. And we're going to have a whole bunch in the U.S. be finishing up their trials very shortly. Just 2 days ago, the Washington Post reported that the FDA is going to have more rigorous standards. I just mentioned this briefly. The vaccine would have to be 50% more effective than placebo. They want to be able to, you have to follow these guys for at least 2 months after their second dose. If there's a 2-dose vaccine, you have to follow them for at least 2 months. You have to document at least 5 severe cases in the placebo group. Even though you may have antibodies against it, that may not necessarily mean it's going to be protective. We want to actually see that there are less cases. If you have placebo cases and vaccine cases, we want to make sure the vaccine actually works and you get fewer cases. And then they have to document at least some cases in older people. So this is some of the new approval processes which we've been put in place. It makes it unlikely that in the next 2 months we're going to have a successful vaccine approved. So again, we can have another webinar once these vaccines come online, and I'd be happy to join the group for that. I'm going to briefly go through some of these issues for, like, when I was at the FDA and we approved vaccines, like, what do we actually do? So first off, we want to make sure the benefits outweigh the risks. And frankly, we're giving this to healthy people. So we got to make sure the risks are low, because you're a healthy person. Why would you even want to have, if you have a bad disease, you're willing to take a little bit of a risk with the safety, because you have a lot of benefit personally to having that treatment for your disease. But for a vaccine, we're giving it to healthy people. So it really needs to be super safe. I'm going to point out efficacy. I have 2 bullets for efficacy. Number 1, if you have a really good vaccine, like, no one is going to get the virus and you can eradicate it from the globe. And that happened with smallpox, right? Everybody got the smallpox vaccine. We eradicated it. The last naturally occurring case was diagnosed in October 1977. So that's awesome. Like, vaccines work. They're amazing. Great stuff. However, just like I mentioned earlier for the flu vaccine, in addition to not getting the infection at all, there's also some efficacy that you already have some antibodies from the vaccine. So even if you do get the illness, it's going to be less severe. I wrote down here Zostavax and Shingrix because these are the 2 vaccines that have been approved for herpes zoster. Zostavax was approved about a decade ago. It's for elderly people who get shingles. And so they looked at everyone over age 60, and they took 40,000 people, like 19,000 got the vaccine and 19,000 got a control injection. And they followed them to see how effective it was. And it was 51% effective overall. So it met that 50% criteria. And that's great. Now, if they looked at people over age 80, it was only 18% effective. That's a 1 in an 8, 18%. So if you go to Palm Springs, California, and you round up 1,000 80-year-olds, 80 or older, and you give all 1,000 people the Zostavax, then the following year, instead of having 12 cases in all of Palm Springs, you're going to have only 10 cases. Now, that's not a lot. That's not really earth-shattering to go from 10 cases to 12 cases down to 10 cases. But the company which made the Zostavax vaccine also looked at things like post-herpetic neuralgia and the severity, and they found that even those who did have herpes zoster, the severity was less. And so therefore the FDA said, you know what? Not only are there fewer cases of herpes zoster, but if you do get herpes zoster, you're not going to have this post-herpetic neuralgia as often. So the FDA approved it based on those two features, on the fact that you either don't get the infection or it's less severe. So, you know, I wanted to point that out because it's a really nice example. Recently, a few years later, or a few years ago, Shingrix came out, which is another herpes zoster vaccine, greater than 90% effective. Okay, for overall, instead of being 51%, it was like 90% effective. Super great, really effective. They did it in two ways. Number one, they added an adjuvant, which is sort of like a sticky, irritating substance that went along with it so that your body super reacts to it. And secondly, they had a booster shot. So you had two shots, you know, of Shingrix. So I want to point this out because when these new COVID-19 vaccines come out, there's going to be different types. Some are going to be like less irritating, but less effective. Others are going to be probably more side effects, but more effective. And it's going to depend on whether, you know, you're pregnant, whether you're elderly, whether you have coexisting diabetes, whether you're a child. And so we're going to have to work all this out. Like as soon as the first couple vaccines are approved, you're going to have to think to yourself, which one is right for me? And I think personally, we're going to be in a situation like that. Again, Zostavax and Shingrix are both good vaccines. They have positives and negatives, and we're going to have COVID-19 vaccines come forward. Safety, there's a lot of people who really want to, you know, take our time with the safety and others who want to go quickly. Clinical trials are good. You know, you're going to get a lot of good data from that, but just keep in mind, in clinical trials, you're not going to have pregnant women, and you're going to have mostly healthy people. I mean, you have to have healthy people. If you want to look at a whole bunch of 80-year-olds and compare a placebo to a vaccine, and like a bunch of these guys have cancer or other serious illnesses, then it's really hard to compare these guys. You know, how do you randomize them? Whereas if you have a bunch of really healthy 80-year-olds, then it's much easier to do. And so normally when these clinical trials are done, you try to get really healthy people of any age. And to throw that into the general population, you don't really know what you're going to get. The second safety thing we do is post-marketing. We can do some really good data. We've been doing this actually. This actually started back with Ebola and some of these other concerns we had in the US, where you can actually get on the Centers for Medicare and Medicaid Services on their website. You can find out who is billing for, who just got a vaccine. You know, they're going to bill it through Medicare. It's going to show up on their website. We can track these people who just got the vaccine, find out how many of them have a specific adverse event like, you know, Guillain-Barré syndrome. And we can follow these people along every week. And we can see at what point does a certain adverse event become more frequent than what we expect from those who did not get the vaccine. And so it's sort of near real time. We can follow these people closely and find out what new adverse events we may have in certain populations, whether it be pregnant women, diabetics, elderly, whatever. And the same can be done with Kaiser Permanente and other health systems that track this data very carefully. So as far as safety, once a drug is approved, we can do these types of studies. And then lastly, there's the vaccine adverse event reporting system. Anyone can enter anything that they want in there. I mean, you name it, I've seen it. So anyone can report something in there. It's usually not necessarily verified. Some things we try to track down to see if it's a true thing, like a death or some other type of severe hospitalization. We try to get more data on that. But mostly, theirs is good for generating hypotheses. If we start seeing people reporting this more commonly, then the team at FDA and at the Centers for Disease Control will start looking into this and saying, maybe there is a problem with the safety, and then maybe we'll go back up to the previous bullet on real-time post-marketing data. where we can actually get, better data on that. In any case, no matter how the safety is done, there's lots of ways to do good safety. I just want to reinforce that the FDA does have law enforcement powers. The FDA can change recommendations. They can change the label as far as adverse events. They can put in new warnings, or the FDA can just pull it from the market and say you can no longer distribute that vaccine. If more data comes in on safety and if the benefits no longer outweigh the risks, then the FDA has powers to enforce. So overall, I think when we get a new vaccine, hopefully it'll be safe. I have faith. When I was at the FDA, there was very little political involvement from either side. It was just scientists making decisions based on the science. I had an extremely good experience my 5 years at the FDA. The senior people that I met with at the senior levels were all exceptionally good, exceptionally honest. They just followed the science. And so I have faith that if the FDA approves a COVID-19 vaccine, then they'll only approve it when the benefits outweigh the risks and that you can feel comfortable taking it. And I think that may be my last slide.
Thanks, Dr. Jankowski. One participant asked to see slide 12 again, so if you could just back up a couple.
Of course.
And show that so she can look at it while we're asking the questions. And
yes,
please submit your questions and any comments you have through the Q&A function, and I'll summarize them and Dr. Jankowski can respond.
Yeah, and if you Google the Washington Post article, it just came out a couple days ago. I don't think you can actually, since you don't have these slides, you can't just click on it. But it just came out in the Washington Post, and there have been other news sites that have also published this.
Yeah, it was also in the New York Times, and it's been in all the popular media, I think. So it should be pretty easy to find, but if you can't, just let me know. Karen.O'Hara@workcare.com, and I'll send you the link. And you can also access this PowerPoint when we post it on YouTube. So let's jump into some questions. I was wondering about, going back to the issue of incentives, there's been some discussion about changing benefits so that people have more reassurance that they can either get paid time off for sickness absence when they don't have that available to them now, and or just greater assurance of job security. And I wondered if you have any comments about that. Just to encourage people to stay home when they're sick.
Yeah, I don't have anything, and I think it's really important that workers feel that they are covered if they have to stay home sick. And there's been a lot of the companies I work with have pretty good resources and have that availability. They're becoming a little fatigued with it. They're worried that some workers may be taking advantage of the largesse. But I think that's probably better than the alternative. Occasionally I'll call a patient and they work as a subcontractor of a subcontractor, and they don't have a physician, and they don't have health insurance, and they don't have anywhere to go. And so I think in those types of individuals, I think there's more of a likelihood that they would go to work sick and therefore be a risk for the rest of the population. So the better safety net you have for your employees, the more likely they're not going to feel like they need to put bread on the table and come in when they're sick.
Okay, there's a related question. What are your strategic recommendations for employees who need to be out of work for flu exposure? And the original question said COVID exposure, and then she corrected it, but it could actually apply to either or. So what do you recommend for an employee who needs to be out of work for exposure and has run out of paid time off and FFCRA paid time off? Are there any legal pitfalls to watch out for if we needed to place the employee on unpaid leave, even if they're quarantined or symptomatic with COVID or flu concerns?
This is a really important question. I wish at some point maybe we can set up to have a legal person on this call. I've had clients who've talked about this. I think this is going to have to be individual basis. I think in the summertime, if somebody came down with what appeared to be COVID-like symptoms, they were pretty comfortable it was COVID, and there weren't a lot of individuals. I'm just, again, thinking back to the wintertime in Washington, D.C., where a lot of people have flu-like symptoms, and you can't have half of your workforce or a half of a department or a division out with the flu and put them on 10-day isolation and put everyone else on 14-day quarantine. And that's going to be really difficult. It may be that you're going to have to figure out a way to test them for the flu. And if they pop positive for an influenza A or B or H1N1, if they pop positive for a flu and negative for COVID, then you could end their isolation once their flu symptoms are gone in 2 or 3 days or 4 days. And then you would not have to necessarily quarantine everyone else who was exposed to them. There's a lot of more, I have a lot of colleagues who are working with other Fortune 500 companies besides myself, and we share emails, and there must be, dozens of emails a day that we share back and forth on new studies that are coming out, or that are preliminary data has come through on this. But in the next few months, just keep up your awareness, and feel free to talk to, if you have a work care corporate medical director who's contracted with you, you're gonna have to contact them and just work through some of these things. And I have a call later today with one of my clients, talking about this exact issue, about how are we gonna test and how are we gonna incorporate flu into our planning, because you don't want to be caught in a situation where in the middle of the holidays, an entire division of, 10 people, like 8 of them are either quarantined or in isolation.
Right. Just a quick response to someone who's asking for the slides, and we'll make the slides available to you after, if you've, anyone who's registered, and they'll also be on YouTube. Couple more comments and questions related to what we were just talking about. Would it make sense to have a company policy to require both COVID-19 and the flu test for symptomatic employees?
If you make it required, that sort of implies that we have availability. And I have not heard a lot about the current availability of influenza testing equipment in acute care clinics and emergency rooms and doctors' offices. I know even for the companies I'm working with, that they don't have large supplies of these influenza kits yet. So I would hesitate to make it a requirement, but as the availability of testing equipment becomes more clear, I think it would be, very helpful to have that. But again, if you can avoid the symptoms to start with by getting a flu shot, even if it's only 40% effective, that's still 40% of people who will not get flu symptoms. And the other 60% who may still, have flu symptoms, they may be so mild that they start having symptoms on a Friday afternoon, and they feel a little sick for Friday and Saturday. And then by Sunday afternoon, they start feeling better and they go to work Monday. So again, part of this is trying to decrease the prevalence within your organization of flu symptoms.
Okay, another related comment. For those of us being conservative in our approach to allowing employees to stay home with any symptoms, we are concerned we'll see high or untenable numbers of absenteeism when flu season starts. I know Canadian provinces have some combination of symptoms for COVID. Do you expect the CDC to adjust its guidance accordingly?
Absolutely. I think the CDC, oftentimes when I'm working with clients, I have to pull stuff from Canada or Australia or Singapore, public health agencies, because the CDC does not have as much granularity in their guidance as some other countries. And I think the CDC will be adjusting their data and their recommendations. As you noticed, I think last Sunday, the CDC had posted that COVID-19 can be spread through aerosolization, which the vast majority of my colleagues believe is true. And in my experience, keeping in mind, I worked on nuclear submarines where the atmosphere is extremely important, and I spend a lot of time on atmospheric issues. I think COVID can be spread by aerosolization. But the CDC, if you recall, put on Sunday, they said it can be spread by aerosolization. And then by Monday, they said that was put on in error, please disregard. So the CDC will continue to update their guidance. And until that time, we're going to all do as best as we can.
Someone just commented that pneumonia and influenza are categorized together on the CDC website, and they're wondering why they're grouped together when they're two different diseases or illnesses.
I don't have
that the pneumonia, if you combine pneumonia and influenza as in one category, then you don't really get a true number of influenza cases.
Yeah, I can't really comment on that. I do know that pneumonia can be caused by multiple things. You can have bacterial pneumonia and viral pneumonia, and so I agree that they probably should not be lumped together.
Okay, here's a longer comment, but it's relevant to a couple of other questions in discerning different types of symptoms and how you evaluate what the person has while they're at work. So I'm going to read you this comment. And it also relates to the person who had cancer, who also has COPD, and he's wondering, how do I even know for sure what I'm suffering from? So the commenter says, I'm an occupational health nurse in a manufacturing plant with 400 plus employees. I'm unsure how to best manage employees who have upper respiratory infection symptoms this winter while the COVID pandemic is occurring. I'm thinking I'll have to require that employees with URI provide us proof of a negative COVID test from their PCP if they want to return to work before their respiratory symptoms are resolved. If we continue to not allow employees to work, if they have symptoms like a cough, we may have too many employees absent. Here's some background. Currently, we do not allow employees to be at work if they have symptoms of COVID. We do the usual screening before employees enter the facility, and we follow CDC guidelines for non-healthcare facilities when allowing employees to return to work after COVID infection. So I think this is a dilemma that's going to be played out, and we're going to hear a lot about in the coming weeks. And what's your opinion, or what strategies do you have to suggest?
My best strategy is, my recommendation, the best strategy is going to be communication. So I have group meetings with some of my companies where I have the human resources person, the building manager, the facility manager, and maybe a legal person. And we talk about, you know, can we afford to lose like 10% of our people, or can we afford to have this person stay at home? And the more you communicate, it seems like at the end of a half an hour conversation, everybody's in alignment. And oftentimes that alignment comes from being more conservative, where the person who's actually managing the site will say, you know what, I think I would rather just have all those people isolate or quarantine, and I still think I can get my shifts running on schedule, and I can organize the workers into pods. So if one person is ill, instead of the entire warehouse being shut down, those 4 people hang out as a pod together. And so if one of those 4 gets ill, I only have to quarantine the other 3. And there's ways that everyone can work together. That's sort of what I've seen in my experience. But if you don't communicate, you're often assuming that what the other person wants. And then the legal person oftentimes is able to clarify that whatever pathway you're going down is not against the guidance from the EEOC or from the Americans with Disabilities Act, and that this is all sort of a good way to go. And sometimes you even have like a union person who, you know, may not necessarily be on the call, but they've already clarified things. So the more you communicate, you have a lot of uncertainty individually, but when you communicate as a group, sometimes you all sleep well that night.
Here's a question related to your FDA experience. Most vaccines are studied and followed for safety and efficacy for 5 or 6 years prior to approval. How do we really prove the safety of a COVID vaccine in only a short 2 to 3 month period? The general population has serious concerns, as we all should.
Hey, that is a super awesome question. That's one that I wrestle with myself. I will share with you that with my experience with the FDA, we had extremely good conversations with the major manufacturers of vaccine. When we're dealing with, GSK or Pfizer, when I mentioned earlier, on one of these slides, these Shingrix on slide 13 and the Zostavax were both made by large manufacturers. And when we sit down and we sort of like iron out our differences and we talk about some of the safety factors, we generally can reach agreement, and we can put warnings for specific populations. We can avoid, excuse me, we can avoid recommendations for some at-risk groups. We can avoid recommending this for children. They may have some data in children, but we may say at the FDA that's not enough. So you can initiate the marketing, but without the children or the elderly or whatnot. So generally, I think the FDA has been super safe and diligent to make sure that we have a safe product, and I'm hopeful that the FDA will continue that. And so we may see some initial vaccines come out, and it may be limited to a certain age range, and those without comorbidities.
Okay, we have about 4 minutes left, so we'll try to take a few more questions. This one's a quick one. How long after immunization how long after a flu immunization is administered does it take for the vaccine to become effective?
Well, that's a really good question. I have not thought of it in those terms. I would think very quickly, because you should be creating antibodies almost immediately, which is why your arm often turns red and swells up a little bit as your body is reacting and producing antibodies. So I have never been asked that question before, so I could be wrong, but I think that it would take effect very quickly. Like within a few days, you are actually producing antibodies against that virus. And if you get the flu virus in those first few days, you already have a lot of antibodies circulating, and as soon as it gets in your nose or mouth, those antibodies are going to attack it, just like it's attacking the vaccine particles that were injected into your arm.
Okay, a couple more questions about the COVID vaccine. Is availability like Shingrix, is it going to be like Shingrix where you want to get the shot, but then it's not available and your doctor tells you you can't get it?
Yeah, the Advisory Committee on Immunization Practices and other national organizations are looking at how we're going to distribute this. And honestly, it's going to first go to the healthcare workers, the pharmacists, the nursing home workers, those people who, are at risk for getting it and are at risk for spreading it to other vulnerable populations. So we have a few million of those people already working in the United States, and they're going to be the first people to get it. And then it'll drift down to other groups. And there have been, I believe there have been, reports leaked on not leaked, but reports that are out there, drafts of what the organizations are considering. And so frankly, for like healthy workers who are not in the healthcare industry or do not have some type of a special need, may not be getting it for immediately. It may take some time to produce more.
Okay, 2 more questions and then we're going to wrap up. This one might require a little explanation for those of us who don't know a lot about ingredients. Why is luciferase in the Moderna vaccine?
Oh, I'll be honest with you. I'm reading all the time on all these new vaccines, but I'm not an expert, and I can't comment on the Moderna vaccine for this.
Okay, I do know from one of our previous COVID webinars that the ingredients in all these vaccines is proprietary, so the general public isn't really privy to the exact combinations of ingredients, but I'm not familiar with luciferase, so maybe we can address that another time after doing some research. So this final comment, I think, kind of wraps up really well some of the thoughts that all of us are having about the current situation. The person says, this is more of a comment than a question. There's no way to prove that if you get the flu vaccine, you will get less sick. Everyone reacts differently, and it all boils down to your immune system. It's disappointing that we don't spend more time educating patients and employees on healthy living, supplementing wisely, sleep habits, etc. Not a question,
That's a great
more
comment.
of a comment.
I love it. I totally agree. You know, people who are taking care of themselves are less likely to get sick. And I know a handful of friends and relatives who say, you know, I still get the flu vaccine, but I don't think I'd get the flu anyways because I sleep and I eat and I exercise and I never get sick. And so I think that's a nice comment. In an ideal world, hopefully everyone listening to this and everyone you work with will just keep themselves in a very healthy state where their immune system stays strong.
I want to thank you, Dr. Jankowski, for your expertise today, and to all of you who are joining us. We appreciate your time and attention. There's a couple remaining questions that just popped in the last few minutes, so we'll answer those for you by email. I'll send them to Dr. Jankowski to answer, and we'll send that along with the copy of the PowerPoint to all the participants. So we look forward to having you on our next webinar. If you're a regular attendee, we'll see you next Wednesday, and we hope we'll have Dr. Jankowski back again later in the flu season. Take care, everyone. Thanks again.